time. It changes with different movements, different postures, different ways you stress your body. The big key thing is it changes. It's not all the time. It's not constant. That's a little bit of a different type of pain that may be more difficult to change, but it's usually due to some sort of joint or muscle tissue sensitivity. So there's rarely a structural cause, meaning there's not typically a bone issue or a fracture or things like that. Do you want to mention anything on that?
It's the most common type of pain that someone will have. We've all had it at some point. You pick something up, you lift something, even weight, or you do a bunch of work around the yard. Something happens the next morning. You have a loss of motion. It's stiff to raise an arm. Your knees hurts when you rise out of a chair. Mechanical pain is the most common thing that you'll feel. It's usually intermittent, like it says on there. It's typically not constant. It can be, but usually it's intermittent, and they're usually very changeable and very fixable. Many times they'll just calm down on its own. Your body wants to heal itself, but if you're having trouble, like where it's just something that's not quite right, can't reach, can't bend, you feel stuck, those are the things that we help with the most.
Okay, on the chiropractic side of things, I kind of mentioned this a lot in my intro, how we're different than the standard adjust-only chiro. So that's the typical traditional model of chiropractic. There's absolutely nothing wrong with that. They help a ton of people, and their main tool is the adjustment, which is great. That can help solve a lot of issues, but there's people that won't fall into that bucket and that need something else. So there's a saying, if you're a hammer, all you see is a nail. Well, if you have one tool at your disposal, that's the only thing you can use, and you don't have anything else that you can tap into or pull out of the toolbox to help people with. So I have extensive training in a lot of different techniques and treatment methods. So I do a lot of dry needling, similar to acupuncture, which is a more targeted like muscle therapy. I have training in this assessment method that Chris and I are both trained in. We speak the same language. It helps us classify people into what bucket they are, and then based on what bucket they fall into, that better guides us as to what treatment options would be best, how they will best respond, how long it will take, and it kind of helps us rule out red flags, which we'll mention here in a minute too. There's also nerve-specific treatment that I'm trained in, so whenever you have pain from the back, neck, anything, there's a whole bunch of different structures that can be involved, and only affecting the joint might help some people, but they might need more nerve-specific treatment or muscle-specific treatment. And having those tools at our disposal helps us reach people that haven't been helped with the traditional model of chiropractic, and helps us get better results.
Even those that feel better with the traditional manipulation, typically what we find is that it feels better because it's, you change the joint, it feels better, you get an instant relief, a reduction of pain, an improvement of mobility. But without something to teach them, something to go home with so they know what to do, 2-3 days later, it's just back again. The positions of our work, of our repeated movements, the things that we do during the day, if you don't have some kind of plan, it feels good to get the adjustment, but then it doesn't last unless you have something to back that up with some specific exercises and movements or these other things that Jake and I do. It's just different than the traditional, subluxation model where it's just, I'm going to get one manipulation, then you're good.
Yep. And also on the PT side, you guys practice a lot differently than the traditional physical therapy model, which is, how many of you have been to like a chain physical therapy?
Someone's had pain in this room because it's too many people that,
Typically you get like a hot pack each stim. They give you a handout with like 5 to 10 exercises.
And say good luck.
Go and do them. Is that the experience that some of you have had? No?
Okay.
Good. Yeah. So on your guys' side, they're a lot more individualized, and we actually had 2 patients mention this week, that you guys take the time to listen and cater the care specifically to them, and not just giving a general packet of here's what you should give them.
The one thing that we find a lot is that people will have some kind of pain, mechanical pain, shoulder, neck, arm, and then they'll say, well, I tried the PT, I tried the chiro, it didn't work. That's like, I don't know if we have any dentists in here, but that's like going to the dentist and it's a person, you didn't like the place you went to, but then like, well, I guess the field of dentistry doesn't work, so I'll never go to a dentist again. That doesn't make any sense. You just go find a different one that treats differently, that practices differently, maybe has different skill set. So going to just one and saying, well, I went 3 times, it didn't work, so then I'm like, I'm not going to do that again, is not necessarily fair to, the science of it still works. You just got to go to someone that you find you have a good relationship with and that you can talk to and get that that treatment that you're looking for, essentially someone to help you accomplish the goals that you're looking for. The one thing that we find is that with mechanical pain, specifically with mechanical pain, you could go to 10 different people and you would get 10 different plans, because there is no standard of care, especially for neck or back, like just normal back pain. It's not referring anywhere. It's just that my back hurts in the middle or to the right side when I move. You could go to 10 different places and you would get 10 different plans, because there is no standard of care for that.
Okay, so here's what
there we go.
the meat and potatoes of it. There are some common myths. I just picked 5 of them that are common that we hear, and figured we'd ramble on about this. And if you guys have any questions along the way,
please,
pop them out and we'll answer them.
We could talk on this for hours, so just, yeah.
So the first one I found was low back pain is a serious medical condition. And contrary to popular belief, a lot of what we do as chiropractors and physical therapists is rule out those serious conditions. Mm-hmm. So spine pain, neck, back pain, that can come from things like tumors, infections, fractures,
the red flags.
Visceral issues like gallbladder, referring to the shoulder.
Central nervous system, something in the brain.
So in our history and exam, that's why we do that. We have to ask those pertinent questions to rule out the possibility of those, and we have to perform the exam to make sure that there's nothing serious going on. Once we have determined nothing serious is going on, then it's safe to treat from a conservative standpoint, which is what we do. So I think,
and the vast majority of people will do well with conservative treatment. I mean, only a small percentage will need to be referred on to something.
These red flag scenarios, these are 1%.
Yeah.
Like, these are not common. I think.
Yeah, unicorns.
Chris had a good example. You guys had Marie not too long ago. She had low back pain.
Yeah.
That was not responding typically how we would expect with treatment. And I think after like 4 times, you guys sent her for an image.
Yeah.
She ended up having a tumor on the spine. Yep.
Yeah, but they respond specifically. That's why we're trained. Like they said, there was that MDT part up there earlier, which is the way Jake and I are trained. It helps us understand. Yeah, first of all, we have to understand and figure out what is the source of the pain. You can't treat something and help something you don't understand. Like that's where a lot of places they see a script from a doctor. Oh, back pain. So they just give you 10 things and just hope you get better. Like understanding if it really is coming from that. Or I had a good example. The girl with the toe pain. Yeah. Like we had one person that had just like big toe pain. It's like, oh, you have sesamoiditis. Sesamoid just means that it's the 2 little bones in the bottom of the big toe where we put a lot of pressure when we walk. And we start talking through it and asking questions and digging deeper, because we have more time than the standard 5-minute office visit with the physician, where they come in and if you don't leave with a script, you're basically like, what did I come here for? For medication. And hers was really just a low back issue that just referred pain to the big toe. So if we just if we just looked at that and said, okay, I guess it's big toe, we're going to give you 10 big toe things, she would have still had that pain. It wouldn't have been successful. But by kind of making sure that is it really a big toe issue? No, it wasn't in that case. Otherwise, you can't treat what you don't understand.
Yeah. And then just 2 days ago, I had a guy come in who I treated on and off, and he had a fall like 2 months ago, and I hadn't seen him for a bit. He came back in, and the pain he was describing was like a vague pain coming down the side.
Mm-hmm.
Man, I don't know. That doesn't sound normal. Sent him for x-rays. He's got 7 broken ribs.
Yep.
So
a fall, but he's got a mechanism. At least he fell.
They never tested for it when he went into the ER, which I couldn't believe. Man, what you described doesn't sound right. So.
Yep.
I just remember you said that several times on here, like, hey, it's the wrist, then all of a sudden, you check everything, and it's the neck that started it. And stuff like that.
Super common.
The ones
say the same thing on a roof. It's leaking in this corner, but you might have the issue over here. It's just traveling down everything and making its way over here.
It's the same. I mean, houses, anything like cars, things that are mechanical in nature that move and things change. That's how it. I mean, the best ones are the ones where we'll get people that'll have. They went to the doctor. They said, well, I have a neck issue, I have a rotator cuff issue, I have an elbow issue, and I have carpal tunnel. Do you think that it's the chance you have 4 different random things all at the same time, or is it just one problem that's referred? And people, they just don't. It's amazing. Who's had low back pain and like just okay? So the experience wise, what was the first thing that you did? Did you go to the doctor? Did you go to a different place? Like what was the general?
I probably sucked it up for years, and then I finally went to the chiropractor, and I've been going ever since.
Okay.
I got an appointment today with my chiropractor.
Okay.
I can't wait to go, actually.
Yeah.
I just recently had lower back pain on the right side, and I think it was from something I was doing at the gym.
Yep.
And I go to Travis Baker over here at Balance Body, but he sounds a lot like you. Like
he's a great doctor.
And I went once, and he did some stuff and put some heat on it, and it was better. But I still can tell, like, if I do certain things, I can tell that might be wanting to come on, but I am a big fan of, I understand exactly what y'all are saying. Some coming in and getting an adjustment is great if you're fit and healthy.
Right.
Yeah, you're not going to stop. You're not going to stop going to the gym and not stop like moving. You just got to keep going back and doing your thing.
Right. So I'm a big fan of the chiropractic that you do because I've had lots of things done with dry needling.
Yeah. Okay. Awesome. Myth number 2 is that scans, so X-rays or MRIs, are always needed to detect the cause of low back pain. Common myth that you have to take a picture of it to be able to diagnose it and understand it. Grand scheme of things,
is 100% inaccurate.
Yeah.
Like it's not true at all.
through the history and exam, you can pretty confidently diagnose someone. And then, truthfully, getting that image rarely is going to change the course of care. So if I suspect a disc herniation, but we don't go get an MRI, or if they go get the MRI and have a disc herniation, the treatment's
just confirms, yeah.
So you don't necessarily need those to say what's going on or to have the right treatment plan.
Right.
Regardless, whenever you have an issue, you should go through 6 to 8 weeks of conservative care, chiro PT, before even considering injection surgeries, things like that.
It really should be in conjunction with, or another piece of evidence, like with attorneys, law. If you'd go into a court case with one piece of evidence, it'd be the slippery slope is really hard. Like you could be all these other things, but you're just looking at one thing. You can get to the wrong conclusion very quickly. But if you have multiple, pieces of evidence that show that there's, pointing to one conclusion, it's more likely to have that. In fact, there's many studies that show that people who have, no pain at all, no symptoms, if you're probably over 40, all the way up into like that 40 to 80 range, way over 50% of people that have 0 symptoms have degenerative disc disease, bulge disc, all that kind of stuff. Like the presence of it being there just alone is not necessarily correlated to being the problem producer. But with a good examination, like I said, a history, all those things, we can pull that piece of evidence and say, that's likely the source of the cause, because it makes sense, it correlates. But there's a lot of things that we can see on an image that it can have a terrible look, especially if you're 65, 70. I mean, the image looks awful. But it doesn't mean that that's all of those things are a problem. It's just there.
There's also research that's been done on the cost of medical care, specifically to low back pain. So if you go to someone who does an X-ray or an MRI right away, that first visit, your cost of care is projected to be at least $2,000 higher for that specific episode of low back pain.
Anybody had like an advanced image, MRI, CT? What did they show on yours?
I have. Well, that makes
Yeah, right.
I have.
You sound a little bit more than.
Arthritis in my lower back, which
Yeah.
I'm actually getting injections for
Okay.
now.
The other thing that we find a lot of times, not always, I'm not saying, but getting that image and getting the information out there with the big scary words, most people, or not most, but some people actually get more fear and more like negative benefit or negative than a benefit out of knowing those things. Because like a good example of degenerative disc disease is, in fact, it's not a disease at all. It just means that as you age, your discs become a little bit degenerated. Everyone has that. But when they call it a disease, it makes it think like, I'm broken, I can't move, it creates more fear, which then because I have this disease, I have to not do certain things. And then there's a negative spiral of not being able to move and do things because you feel like, hey, I'm broken because I've got this scan that says I have all these bad things, when in fact, they're probably just normal signs of age-related changes.
Next one, pain with movement and exercise is a warning that harm is being done to the spine. So it's important to understand that just because something hurts when you do it, it doesn't necessarily mean you're making matters worse or aggravating things. It could just be like that mechanical response. You're just producing pain. You're sensitive to that movement, but you're not necessarily tearing tendons or shifting bones or anything crazy like that. It's just sensitive.
Yeah. It's a very normal part of the rehab process. Anybody who's had pain understands that when you go back to doing things, it gets a little sore. And then typically when you stop doing that movement, it usually calms down. Like a good test, if everybody just pulls their finger back and holds it, after 10, 15 seconds, it starts to hurt. That's a mechanical stretch on that joint. Then you let it go, goes away. You're not doing any damage to that joint. You're just putting a structure on end range strain, and your body's telling your brain, hey, don't do that, it hurts. But it's not wrong. I mean, you're just testing end ranges. So it's okay to have a little bit of, there are red lights. I mean, we go through like green light, yellow light, red light when we work with somebody to understand that, red light truly is some kind of pain that refers or goes further down an arm or a leg and remains worse afterwards. That's a red light. That we can't do. Yep. But we get a lot of yellows where that hurts to do, put it down, no worse. Hurts to do, put it down, no worse. And if you stop because you hit a painful area and never explore that again, you'll miss a lot of the green lights where after 10, 15, reps, all of a sudden it's like, oh, now it doesn't hurt as much because you didn't ever explore it.
And that goes into our next point. The pain flare-ups are a sign of tissue damage and require rest. Yeah. So number one, rest is almost never the option, never a good option for any spine, muscle, joint pain. But speaking to that regard, the green light, yellow light, red light aspect, producing pain is sometimes necessary during the rehab process because or
temporarily increasing because you're loading tissues.
Yeah. Imagine your tolerance level is here. You have an injury or you irritate that tissue. Now your tissue tolerance level drops, right? As you're building it back up, it's like working out. When you work out for the first time after a while, you're sore.
You're sore, yeah.
And then after a while, you start to get stronger and stronger and stronger.
Then the same lifts don't make you as sore as it did 3 weeks ago.
Same thing applies to joints, muscles, tendons, ligaments, even nerves. And then the last point here, treatments like medications, injections, and surgeries are effective and necessary to treat low back pain. So again, with most people having a mechanical issue, right, throwing pills, painkillers, muscle relaxers.
Passive, that's all passive stuff.
They might deaden the pain signal, but they're not fixing any issue. So it's just making you not feel the pain, which I know is what most people don't want. They don't want the pain. But as soon as you take those away, you're going to start feeling it. Mm-hmm. So there is a time and place for things like injections and pills like that, especially in the cases where we get really bad shooting arm pain or really bad shooting leg pain. If we put those people on a steroid pack or send them in for an injection, boom, that opens up a window of opportunity where their pain level is now diminished.
Then we can get back to doing stuff.
Inflammation's knocked down, and we can start working them back into movements to fix the underlying mechanical issue.
Part of that chain, that's not the right slide, but part of that goes in the transition from mechanical to chemical. If it's chemically driven pain, inflammatory, disease process, certain things like that, then you do need to use some kind of, because medications, right? So these are chemicals. These are all chemicals. Anti-inflammatories, medications are chemicals. They help and do very well with chemically driven problems. But the vast majority are mechanical problems, so they don't mesh. Chemicals don't necessarily help with a mechanical thing. A mechanical helps with a mechanical, and a chemical helps with a chemical. Yep. So you got to match the right problem with the right solution.
And then on the topic of surgeries here, most people with disc herniations are concerned that they will need a surgery. There was a study done with 280,000 patients, and 97% of them were able to have a successful result without surgery. Same thing applies to most things spine-related or not needing surgery. 90+%.
Yeah, but the ones that do, it's usually pretty evident. It's pretty clear. I mean, there's some kind of, like we talked about the red flags. There's progressive neurological weakness. There's constant symptoms that we just cannot change based on position, time of day, movement, activity. Most things will change based on, I can position myself a certain way. It feels better. I feel better when I'm up moving around, and it's worse when I'm sitting. Those things are like that wave, typically mechanical. Those are changeable. Yep. But the ones that are that would require, and then when it's needed, the surgery is the best thing to it fixes the problem very quickly.
Yep. And I'll briefly show you guys.
Ooh, the X-Pos is great. Yeah, that's.
So this is a big part of what Chris and I do and help people with. We get a ton of shoulder and hip patients, people with shoulder and hip pain that have actually a handful have had surgeries or have been suggested surgeries for their shoulder, and within 15 minutes in our office, they're back to full range of motion.
Shoulder pain's gone.
Decreased because it wasn't a shoulder issue.
Yep.
It was a lower neck issue referring pain to that shoulder. So
what this stands for is extremity pain of spinal, origin or spinal. That's where it's source. That's where it starts. So take me, you guys can probably all relate to this. Who here was either an athlete in high school or college, likes to lift weights, be overhead things or pushing, pulling? Everybody at some point did that, right? So if you have a shoulder pain, like my arm hurts, my shoulder, my scapula, maybe down into the bicep, if you go in and say, well, my shoulder hurts, again, you'll get about 5 minutes and they'll do this and get an MRI. The chances you have a torn rotator cuff in your dominant side, if you threw a baseball, you threw a football, you lift, push, pull, very high. It's going to be there. And so you get this faulty or this slippery slope where, well, I see this, so it must be this. When in fact, what this study went through almost 370 people is almost 50% of shoulder pain alone. No, this means there's no neck or upper back pain whatsoever. It's just shoulder pain. Half of them, the pain is actually originating from the spine. So that's literally flipping a coin.
I'd argue
That's
higher.
yeah. It's probably close. We see probably closer to 6. Yeah, I mean, but it's like well, you can't not. It's a double negative. You can't not look at the spine at least for 10, 15 minutes because the chance. I mean, you're going to miss half of them. Like that's not a very good outcome. If I'm only batting 500, that's not good. I mean, I guess in baseball it'd be, but not in real. Yeah, I know, but no, not in what we do. We like to hit way closer to not high 90s, not 50%.
So that's a key thing that what we do is we take the time to go through like an algorithm. I mean, it takes a good 30, 40 minutes on that first day, and then a couple days after to confirm.
But if you can save someone from a $40,000 shoulder surgery that didn't need it, and then they come back and like, oh, the pain's still there. Huh?
Right.
Yeah.
Yeah. So we see a lot, mostly shoulder and hip, but other.
But even like calf, heel, like that gal with the toe pain, 30%, 3 out of 10. That's too high too to not at least look at it for 10 minutes.
Yep. Those percentages are showing the percentages of people that were like recommended for surgery.
No, this is showing that. So the overall is about 43%, but per joint it's showing that 48%, almost 50% of just shoulder pain. The actual origin was from the spine because they moved them around, they tested them, they figured it out, and they got the pain to go away. So half of people that have shoulder pain, half is actual shoulder, and half is the neck. And so hip is really high. I mean, look at 70%. If you have like hip pain out here, 7 out of 10, it's not even a hip. So they'll get, oh, you have, greater trochanteric bursitis, or you have, all these different things that it could be. It's like, 7 out of 10 is just a back thing. So you mean you're literally that's over half that they're not even,
Got to test it. Here's just a couple quick cases, just some quick before and afters of, these are usually taken like 20 minutes apart. People that can't move, and then we quickly increase the range of motion. This guy ran 100 miles and had some swelling in his leg, so I just loaded him up with some dry needling.
Well, the problem was running 100 miles more than that's.
She was very, very stiff when she came in. She was going to a traditional adjustable chiro, and she was getting relief, but nothing that would last more than 2 days. So we were able to throw some other therapies in with her and get some lasting changes. Scott here, he had a history of a disc herniation that it required surgery, so he got surgery, aggravated it. Initially, we were able to make some very quick changes, and then like 2 months later, he aggravated it again, so unfortunately, he had to go get another surgery. So those cases do happen. They're rare, but again, surgery is right for the right person at the right time.
And we're there for before and after. Like, if you need to have it, we'll still help you, obviously afterwards.
And I like this guy, just because first day he came in, he's like 28, I think, and his doctor told him that he has a torn rotator cuff and he's never going to lift weights again. And I think Brendan and I were working with him, and we started laughing. We're like, dude, we're going to have you lifting weights here in like 20 minutes.
Yeah.
You're not going to believe it. Sure enough, there he is lifting 35, 55
Yeah, it's 20. Yeah, 25 plus the bar is 35. So.
Yep.
Speaking of the lifts and the weights and everything, I'm going to ask the question that everyone in the room is wondering.
Please.
Who wins out of arm wrestling competition?
I win.
3 times a day, so he better win.
I'm it was on Chris.
Yeah.
But no offense.
we have had some bench contests in the office there and do pretty well. I do win those. Yeah. I have short arms. It helps.
All right.
Just mechanics.
Yeah. Last thing I want to mention is I'm very active on Instagram, as most of you may know. So I post a lot of good, useful content. I don't know, just tips and tricks, some treatment videos to kind of show what all we do. So if you're interested to see how we treat, how we do things, you can check that out or send that to your friends that have issues and they want something fixed. We do some educational stuff on there. Basically just try to help people better understand and find solutions for these things. If you want to hear me dive into all this stuff more, there's a podcast I did where we kind of just went deeper into this discussion on what we do and how we help people.
I didn't know you were on that one. Good job.
Yeah, that was a good one. Other than that, the only other tip and thing I can help you with is if anyone has interest in Instagram marketing, I've had some success with it. I'm no expert by any means, but I'm happy to share any of the knowledge I have from that. Any questions?
Yeah, questions.
Nothing.
The group is silent. Nobody has a pain right now that they want fixed. See? We do that all the time. Like what's going on?
I just got lower back pain, but
Okay.
I've been going to my chiropractor for several years, and I really enjoy them. I don't like the crack and popping.
Yeah.
Like
It was fun, yeah.
The
Activator?
Yeah.
Did they give you some things to work on in between, or is it just okay?
Yeah. I'm not really good at doing homework though. I guess I did have a question.
Yep.
And don't judge me, but I mean, like, I sleep with like my dog, like with my leg on my dog. Like, I'm spooning my dog, and that seems to help my back.
Yeah.
Yeah.
Yep.
Is that a real thing, or am I just mentally crazy? Or?
Pillow up on the, no, it's.
It opens the hips better. Just put you in
Yeah, like my hips are open, and yeah.
And sleep. Yeah. And sleep is really important. That's an underrated, treatment as well. I mean, people ask sometimes, like, what's the best position to sleep in? Any way that you can, just get the sleep. I mean, you need hours. That's when your body and your brain and your nervous system, that's when everything is healing and remodeling and taking care of all those, those tissues that have been injured throughout the day. You have to be able to sleep for, good, 7 to 8 hours if possible. It doesn't matter what position you're in as long as it's comfortable enough to fall asleep. But that's underrated.
Follow-up question to that would be: Is there prescribed pillows or beds or things like that help? Yeah, common question. There's no good answer. Everyone's individualized.
The one that helps you,
what might not help me, might not help Chris. I saw this bed that had like a big crack one, so you could stick your arm down there.
Yeah.
That's what I want, because I always sleep with my arm.
Yep. If you can get one that works for you, that I said, whatever position, if you're side, or back, or some kind of sometimes that semi-prone position, like a roadkill, where you're almost like you're someone on your side, someone on your stomach, and you got that leg up. That's a lot of times comfortable for low back things. Yep, that opens things up.
Yeah, that helps me.
We got an adjustable bed, and my husband is getting relief just lifting his feet up a little bit.
Yeah.
There we go.
So
Takes strain off a little bit.
Yeah. Because if it helps and it allows you to do more things the next day, like to be more active, then it starts to spur a positive feedback loop, as opposed to, I'm sore in the morning, so I can't do anything, and then it feels better. I can do more things.
So I guess in that regard, some people with low back pain find like laying on their back, throwing a pillow under their knees,
to flatten things out.
Flattens their back. Or people with neck and arm pain, sometimes they prefer no pillow at all because it keeps them.
It depends on the height of the If it's too big and it pushes you forward, you don't want that. If it's too thin and you're back, or you're too far to the side, you got to try to be in neutral as much as possible.
Yeah, I use almost no pillow and sleep on my face.
Yeah.
It's fine. Yeah.
I have like a small corner of it, but my son, my youngest son, is the only one I know that 100% always sleeps on his back. Like half time it's like this. And he's the only one I know that can do it. My wife hated that when she was pregnant, having to sleep on her back.
Oh, sure.
At certain times of it.
No, to me, to sleep on, I cannot sleep on my back, but it just seems like it would be healthy so you're not squeezing.
I'm not comfortable that way either. No. Just like a coffin. Like a coffin. Yeah. In a coffin.
Does your dad have fangs?
Doesn't go out during the day?
Here's this picture of him on Christmas morning with he's just tired, obviously. But there's wrapping paper everywhere, and then he's just sitting there.
Ow.
It's a great picture. That's comfortable.
I do.
Good job, guys.
Yeah.
If you have shoulder pain, and I think it's from years and years of carrying heavy books. So like in my industry, the window shades, the books are really heavy.
With all the examples,
and I go back and forth with the car, so I would carry two and return.
Yeah.
And I think over time, it's just really, so it's like I can deal with it during the day, like I don't even need anything, it's when I sleep.
Yep.
So I lay on this side and then it starts to hurt, and then I flip over the other side and this starts to hurt. So it's right in here.
Yep.
So
60-70% shots your neck.
Yeah, you have to. It's quite possible. I mean, the one way to differentiate would be to just pick one place first. The one thing that we were trying to get, I don't know if I covered that well enough, but when you go to chiropractic, physical therapy, any kind of service, and if you're getting on the first visit 5, 6, multiple things to do at home,
Too many variables.
the trouble with that is, you don't know what the cause and effect relationship is with all of those things. So the one thing to figure it out, or to start narrowing down, is to just pick one thing and try it for 24 to 48 hours and see if there's a difference in the way that you sleep at night. If not, move on to the next thing. But if you do 5 or 6 things and then all of a sudden that shoulder pain is better or worse, how will you know which one it was? There's too many variables in that equation. But the one thing to start with would be to take some baselines, how high does each arm, go, and take some baselines. and then just pick, like Jake and I would probably pick at least the neck to start with for just one day. I mean, you've had it for years, which 24 hours and, trying something. And then you just retest those baselines and see if you're overall any different. If there's even a slight something different, like, it wasn't as sore, then you can explore deeper. Yeah, you got to go further and deeper into the end range, go more load. But if you did like, well, I'm going to do, some bands this way and some bands this, and all these things, and it's like, well, it's not any different or it's better or worse. There's too many variables. It really muddies the water as to figuring out what the cause is. But yeah, for us, it would be just to start with baselines, strength, range of motion, everything else. Yeah. Then work into the neck, lower neck, upper back, and then retest those. But you have to do like 70, 80, 100 of those reps throughout the day. Just space them out. And then if something's there, it will change. You'll be like, ooh, it's different. But even if it's worse, again, it's just information. Yep. Then we know that something's there, and then we have to just regress the load of the force a little bit. And if it's nothing, it's like, nope, it's no different. Okay, we can cross one thing off the list, then go to the shoulder and start messing around with different directions. Yeah.
Cool. Thanks, guys.
I'm curious. We'll do the questions next week, since it's 54. So